Okay, let's get started. Welcome everybody to Rush University Medical Center Division of Nephrology Renal Biopsy Conference for May 6, 2021. Today's CME activity code is 482404. As usual, these are being recorded and will be available on YouTube in a few weeks. Please join our channel. We want as many people involved as possible. The cases have been de-identified. We would like for the non-faculty to put all your questions in the chat box, and we'll try to get to them as we go through the case or at the end. Let's get started. This is a case of mine. No surprise, it's a patient with lupus. I'll be presenting the case and have some discussion after the case as well, related to some of the issues that I think are relative to this to the case. So the patient is a 25-year-old Black female with a past medical history of Graves' disease that was diagnosed 3 years ago. She presented at that time with palpitations, tremor, diarrhea, amenorrhea. Her free T3 at that point was very high at 3, and her TSH was less than 0.002, normal being anything above 0.4. So she was severely hyperthyroid. She was treated with a beta blocker. Initially, she only wanted it treated naturally. She even at one point wanted to get some medical marijuana. And it's kind of relevant to this case, as you'll see, her reluctance to being treated. 3 months later, she was found to have a sore axillary mass, and a CT of her chest showed both axillary, mediastinal lymph nodes, which were eventually biopsied and showed just follicular hyperplasia. There was no evidence of malignancy. So they went ahead and did some autoimmune serology at that time, which showed an ANA of 1 to 1,250, a double-stranded DNA of 41, normal is less than 4. Her Smith was elevated at 4.3, normal is less than 1. Her rheumatoid factor was 55, normal is less than 30. Her C3 was 111, her C4 was 13. Those were both normal. The lower limit of normal for C4 is 13. There was no follow-up until she finally saw rheumatology about a year later for some knee and wrist pain. She'd been having a lot of knee and wrist pain off and on for years, but it had been ascribed to basically athletic injuries, so it's unclear. But she also had a history of Raynaud's, and it was that point she was suggested, her urinalysis was normal, and it was suggested that she take 4 milligrams of prednisone and start Plaquenil. Around this time, she finally started taking Methimazole for her Graves' disease. But there was essentially no follow-up, and it was unclear if she took any of this for the next couple of years. Then about 6 months ago, urinalysis was done. It was unclear why it was done, but it had greater than 300 milligrams of protein and large blood on dipstick, but there was no micro examination. Then she presented this admission now to rheumatology with joint pains, pleuritic chest pain, shortness of breath, and hypertension. A chest pulmonary embolus CT was negative, and she was admitted to the hospital. She denied edema, hemoptysis, flank pain, or gross hematuria, but she had been taking ibuprofen fairly regularly for her joint pains. Her past medical history was significant for her Graves' disease, patellar tendinitis, acne, iron deficiency anemia. There was thought related to her periods. Her past surgical history was only significant for her axillary lymph node removal for the diagnosis. Her social history, she didn't drink, but she did use marijuana occasionally. There was no family history of renal disease. Allergies, she was allergic to bee stings, but no medication allergies. View systems was as above. She was taking pantoprazole, lisinopril, atenolol, methimazole, ibuprofen, and iron tablets. On physical exam, her blood pressure was 160/100, her pulse was 107, her respiration rate was 18. She's 5 foot 3 inches and 130 pounds. She was alert and oriented, but she looked slightly uncomfortable. You could tell she was in a little bit of respiratory distress, a little bit of pain, and a little bit of shortness of breath. There were no eye findings of Graves' disease, oddly enough, since she was fairly significantly hyperthyroid. There was no lymphadenopathy at this point, appreciated on physical at least. Her lungs had decreased breath sounds at the bases, but no pleural rub, and the heart was normal, no pericardial rub. Her abdomen was soft and non-tender. Extremities were unremarkable. She had no rash and no edema. And I'll show you the chest x-ray here. On present, yeah, you can see where it was 3 years ago, fairly clear lung fields, pretty clear margins there. And then on the right side, you can see that both of the, the margins are filled with bilateral pleural effusions. It's difficult to tell the heart size, but I think it was read as the same. So now she's got fairly significant bilateral pleural effusions. On laboratory exam, this is now presentation. She's got a sodium of 136, potassium of 4.4, a chloride of 106, and a bicarb of 21. Her BUN was 11. Her creatinine was 0.8. Her blood glucose was normal at 74. Her total protein was 7.2, but her albumin was quite low at 1.4. Her calcium was 7.5. Her bilirubin was normal. Her alk phos was 156. Normal is less than 125, but the other liver enzymes were normal, the AST and ALT, and her total cholesterol was normal at 135. Her CBC had a white count of 7.9 thousand. Her hemoglobin was 7.6 with this very low MCV. Her platelet count was normal at 569. There was a normal differential, and her iron saturation was only 6%. Her free T3 was now normal, as was her TSH. So the methimazole was doing its job, apparently. Urinalysis now at a specific gravity of 1.025, a pH of 7, greater than 300 milligrams per deciliter of protein. Of course, this is a dipstick. Large blood, 15 to 25 red blood cells, 50 to 100 white blood cells, and a protein creatinine ratio of 1.3 gram per gram. Her double-stranded DNA was greater than 300, quite low now, or quite elevated, and her C3 and C4, which had previously been unremarkable a few years ago, was now 42 and less than 3. So she went from C3 of 111 and 13 to now 42 and less than 3, since originally having serologic diagnosis. And her urinalysis several months ago was abnormal, and it remains quite abnormal. Renal ultrasounds showed the kidneys would be normal in size and echogenicity, and a percutaneous renal biopsy was performed. And I'll take any questions about the clinical presentation if anybody has any.
Yeah, is she menstruating?
Well, she is now, yes. I mean, she's not menstruating during this urinalysis, but she was.
No. My issue with the iron deficiency, whether or not she's still actively menstruating, just as a possible reason for it.
Well, that's been the thought, and she's been on iron, but her compliance has always been in question. So, I mean, she's been on iron supposedly, and she's still quite iron deficient and quite microcytic. Any other questions about her presentation? Great. Dr. Gashti, you want to start us off with a discussion?
Yeah, sure. So 25-year-old young woman with what appears to be previous episode of autoimmune thyroid disease and prior diagnosis of lupus. Years ago, really not on any immunosuppression, on a whole slew of drugs that would be sort of a minefield for a board exam for a nephrologist, everything from a PPI to NSAID to ACE inhibitors to ANCA-associated methimazole-induced vasculitis. All of them are on her med list. So now comes in essentially with really significant hypoalbuminemia, although she doesn't have significant nephrotic proteinuria, but and normal kidney function, but very active serologies, and essentially a ton of symptoms. Seems like fluid overload, pleural effusions, sort of a pleuritic symptoms. So this looks like, obviously, the biggest sort of elephant in the room, I guess, here would be the lupus have flared, and she has some kind of a nephritis given all the pyuria and hematuria and proteinuria that she has, and her systemic manifestations are also part of lupus. Because the creatinine is normal, I'm less inclined to call this any kind of an interstitial nephritis from an NSAID or PPI, but minimal change disease from either NSAIDs or her lupus in a shape of podocytopathy or on the differential. Her lupus itself could have a proliferative lesion despite a quote unquote normal creatinine. She could actually have a proliferative lesion, which I think she probably does based on how active she is serologically. So I think she's going to have one of the class 3 or class 4 proliferative lupus lesions, either focal segmental or diffuse proliferative lupus. And so that's kind of be my number one, is a proliferative lupus nephritis lesion. Membranous, it's definitely a possibility. I mean, her albumin is 1.4, so that's always a possibility. The serologies don't really distinguish between a proliferative and a membranous in this particular case, because they could both be pretty active. But she has a lot of blood and a lot of pyuria, so that's a little less likely to be membranous, but you never know. I mean, UA is sometimes not entirely reliable. So if we take this whole thing together with the clinical presentation, with the systemic presentation, I would say she's got a proliferative lupus nephritis, as we're going to see that on histology.
How bad do you think it's going to be?
I think she's going to have necrosis. I don't know about crescents. It's hard to tell. She's not an RPGN, I know, but we've, 25-year-olds, we see this all the time. Creatinine is 0.7, and they've got crescents and necrotizing lesions in the kidney. So I think it's going to be bad based on how hypocomplementemic and how high her double-stranded DNA is and how much systemic disease she has. Lungs seem to be a big focus of involvement with lupus here.
And you had a good point there too about how systemically sick she is. And I think that might be her albumin being low. I mean, it's possible that she had more proteinuria at some point, but her albumin's markedly on the floor. Her cholesterol is normal. She doesn't have really that much any edema, and her PC ratio is only 1.3. So I kind of feel like it's just another manifestation of her being so sick as opposed to nephrosis. And I would expect her podocytes are going to look pretty darn good compared to the immune complex lesion that she'll likely have. I think that's a little bit of a clue there that her albumin may not represent nephrosis.
All right, I'm going to take another slant at this. I know you're not calling on me, but I'm going to go ahead and pipe in anyway.
We can always
see some of these patients who have had low protein creatinine ratios with extremely low serum albumins. Now, it's interesting, she doesn't have edema, but she definitely has pleural effusions. And unless someone's going to tell me she's got cardiac disease, which I don't get the impression she's got, I have a feeling that, if you were to give her albumin infusions, her urine protein creatinine ratio could shoot up substantially. And we've seen that before. So I think that with an albumin of 1.4, the protein creatinine ratio may be misleadingly low because she's basically so, I guess, hypoalbuminemic, if you will.
I think that the cholesterol helps out there, though, and it gives a little clue that it might not be that. I mean,
well, that's a good point. We've talked about that before. I personally think she's going to have membranous lupus or possibly even a podocytopathy, and on top of that, a proliferative lesion like a 4S lesion. Especially she's African American. I agree that there's I would expect something active given her urine sediment, but I'm leaning more towards having something additional, like again, a podocytopathy or a membranous coexisting lesion.
So Steve's point's good, and that the proteinuria might be influenced by the serum albumin, but the problem with that is we see patients all the time with albumins of 1, and they still have 20 grams of protein. So I don't know, I don't know why some people would have that and some people don't. I mean, your best example of your proof of concept, if you will, is if you give them albumin, it goes right into the urine. But I don't know that necessarily is protective either, that the low albumin lowers their albuminuria. I don't know. I haven't seen that, but it's always a possibility. And that's a really good point here, is that, she's got an albumin that's on the floor, and yet she doesn't have a lot of proteinuria. And then Bill's point is maybe it's just her chronic illness and reflecting on just how severely ill she is. But who knows? We'll have to see what the biopsy shows to kind of sort that out. Casey, somebody in the chat wrote, what about amyloidosis from chronic inflammation? Do we see amyloidosis in lupus?
Not really. I mean, I don't know of the association with lupus.
It's interesting. I mean, I haven't seen it. I'm sure there's cases, of course, but we think of it more with rheumatoid arthritis and some of the others as opposed to lupus. Steve's shaking his head.
No, I mean, it's an interesting thought. I haven't seen it with lupus either, but the other caveat here is, and we've talked about this before in these conferences, people that have, ulcerative colitis or rheumatoid arthritis or chronic suppurative and inflammatory processes. I mean, there were papers some years ago, I'm sure they've been for a long time, but the fact is that you don't usually see the secondary amyloid until they've had these inflammatory processes for 10 to 15 years. So unlike AL amyloid, where it may occur relatively quickly, with these inflammatory states, it sometimes takes, years for it to develop.
I think that's a really good point too, because in the past we didn't have good treatment for RA, and so they would be chronically inflamed. They got anti-inflammatory agents, but they didn't really attack the disease, so they weren't turning it off. Whereas lupus, you can't really have inflammatory lupus for 15 years. So that may be actually a very good point. Maybe the reason we don't see it. I haven't seen it. Again, doesn't mean it doesn't exist, but I think that would be pretty low on the differential diagnosis here.
It's one thing I just wanted to, it's 6 months ago, she already had what seems like to be an active sediment already, which is kind of concerning. It's 6 months and she still has a normal creatinine, which, and she was on 4 milligrams of prednisone if she was taking that. So you'd think if she had something very aggressive, either again, the creatinine is lying here or it's something smoldering, or she that would maybe go along with more membranous as some people had on their differential over a proliferative lesion. But
the other point would be, if these secondary amyloids for inflammation, it's SAA that's elevated. And I'd wonder if anybody's actually looked at the SAA levels in people with lupus like they have with rheumatoid arthritis or ulcerative colitis. I'm not aware of it. I don't know.
Yeah. Pravir, along those lines, I mean, she's been sick for a while. What would you predict? That's maybe a little premature, but what do you predict about chronicity in her?
Well, I think she's been sick for a while. How much chronicity, based on, if this 6 months of, she had a, proliferative lesion, you would think that some of that would be scarring by now, and there will be a chronicity, but creatinine is 0.8. And so, I would hope that, I think we won't see as much, maybe 10, 20%, maybe a little more than you would see in a 25-year-old. I don't think we'll see 50 or 75% just based on the creatinine. But, I think she's been systemically sick, but her urine really has only been active that we know of the last 6 months. And so I think we'll have a little less, we'll have 20%, 30% max. I think there'll be a small element of chronicity that's out of the scope of her age.
So just a few comments from the board here. One is IgG4 related disease given thyroiditis and lymphadenopathy. Now, I know certainly that IgG4, this patient has lupus, so you don't really have to give her something else, but it's still worth talking about. It's a midline kind of inflammatory disease, and I think more of destruction of organ than stimulation of organ. So I think of Hashimoto's disease, and Riedel-Struma has been kind of associated with that. Does anybody know if Graves' disease is actually seen with IgG4? Yeah, I don't know. I don't know. I don't think so, but I could be wrong. It says also IgA. I don't know about that. She's African American, and we know she has lupus. But there's a question about the pyuria, and I think that's interesting too. Steve, what do you think about pyuria in a patient with lupus? I'll tell you the urine culture is negative.
Yeah, I mean, that's a lot of pyuria. I mean, I guess the interesting thing about that, I mean, first of all, I'm not surprised by it because they can have fairly inflammatory lesions. But she's on the pantoprazole, the PPI, which may be a possibility as well. I mean, it could be an interstitial nephritis coexisting with this, but that said, it's kind of, that creatinine of 0.78, it's hard to make it, it's hard to really kind of suggest that she's got a widespread interstitial nephritis that would give her that kind of pyuria. But an active lupus lesion, I mean, you can see some white cells. I mean, you don't usually see exudative lesions, like you do with post-strep. And it does seem like a lot of white cells. That's why I wonder whether that's a result of, one of the medicines she's on, like the PPI or even the ibuprofen for that matter.
Yeah, I'm always not surprised how much pyuria, I don't know if I've even seen much literature on this, but how often pyuria, we think of GN as purely a kind of a red cell disease, but it's certainly, and not just, post-infectious GN, but a lot of these can have a lot of pyuria. It does seem like a lot, but it may be a clue to her degree of inflammation. Casey, you had mentioned methimazole. You want to elaborate on that just a little bit, and I'll tell you a little story?
Well, we had our last biopsy conference was possibly a hydralazine-induced vasculitis. And so when you had that table of medications, and methimazole was definitely, PTU, methimazole were on the list of drugs, thyroid treating drugs that can cause an ANCA-associated vasculitis. So that was fresh on my mind. That's why I brought that up.
It's funny. I thought it was associated with minimal change. I don't think I realized the vasculitis one. Maybe the minimal change is wrong.
it's one of the more common associated with vasculitis. And I tell you, when I was reviewing the case yesterday, I went through it and it was fresh on my mind because it was last week, and I did talk about drug-induced vasculitis, and I felt like, somebody hit me over the head that we had totally missed this case. Because a lot of these drug-induced vasculitis or drug-induced glomerulonephritis can be kind of an overlap syndrome. A lot of, the hydralazines, is it lupus? Is it vasculitis? My point was, who cares? It's drug-induced. I said, maybe we missed this case. And I went back, and her thyroid disease preceded all this, but she didn't, it took me quite a while to find out when she started the methimazole. And it was clearly after we had serologies, after the biopsies and everything. But for about an hour there, I thought we had totally, and I was on service at the time that she came in, and I totally felt like I completely blew it and missed the most obvious cause of her GN. But the methimazole definitely been documented to be started after her lymphadenopathy, her biopsy, and the serologies. So I think we should spin the wheel and see who's going to read this biopsy.
Well, I hope Faraz is ready, because it seems to hit him every time.
I don't know. So Asim is gone, right?
Yeah, Asim is away.
Of course, it goes to Asim. The wheel's a troublemaker. I don't know.
The wheel has no boundaries.
I think it's Dr. Corbett, because it came to Asim twice. And you're next to it, Steve. So you get.
All right, you're gonna have to put that weight somewhere else on the wheel, so it doesn't hit one on the same
All right,
person.
Steve, give me a second here.
All right.
I'll share my screen, and I'll give you control.
So here we have a trichrome, low powered. Who did did we do the biopsy?
Yes, we did.
With a 16 gauge needle?
I believe so.
Either way, it's just interesting how a bunch of these are hanging off the side, but a nice core with respect to the number of gloms. Not a lot of scarring here. I mean, there's some. Is Dr. Simblick around?
Yep.
All right. So, I mean, there's probably maybe 10% at best.
That's it. Hit the nail on the head. That's what I said.
Yeah. Well, I guess I was reading the report right. So a lot of gloms, which we'll see at higher power. I don't see really any globally sclerosed ones at this point. Okay, here we've got an H&E. And I think now, I mean, looking at a higher power definitely has its benefits. And I'm glad I didn't say anything at a lower power, but look at the interstitium, and there's a lot of interstitial infiltrate here, a lot of nuclei. These aren't dead tubules. So I think there is an interstitial nephritis. Do you agree,
Right.
David?
Yep.
We'll see what kind of cells they are as we go higher. But there's no question as well, these gloms, boy, I like this pointer. This is awesome. They are very proliferative. I mean, and we'll get a probably even higher power yet, but I mean, it is amazing given that creatinine of 0.78, that at this power, even you see this diffuse mesangial hypercellularity. You see, what we used to call endocapillary proliferation, which has kind of been abandoned. But even at this power, you can see a lot of the capillary lumens are occluded by nuclei and cells. So we'll see a higher power of that. But very active interstitial, as well as glomerular inflammatory processes. And I guess an aside, lupus can have interstitial nephritis associated with it as well. Oh my goodness. So, I mean, at this point, we've seen 2 glomeruli. This is a third different glomerulus. I mean, we've definitely at this point got a diffuse proliferative glomerulonephritis. And there are some lumens that you can see are open, but there is a lot of mesangial hypercellularity, and a lot of these lumens are occluded by cells. I don't see, at least at this power, which is still a pretty good power, I don't see polys, which we talked about, because of the white cells, which could be lymphocytes as much as anything in the urine, but monocytes too. I think this is the vascular pole. And this, I don't know, Dave, I was looking, this isn't a crescent.
No, but I think there's a little necrotizing lesion right in that area.
Right here?
Yeah. And above it, to the right a little bit.
Right,
Yeah,
this
right
is
in there. Yeah.
fibrinoid. I was looking for maybe that's a caryophyllus, but
Yeah.
so there's a little segmental area of fibrin and necrosis. I don't know if there's some over here, but I mean, there's no question this is an active and inflammatory lesion.
Right.
And again, you know, just we've talked about this every time. You know, the creatinine is just so misrepresentative of what you see oftentimes with regard to the histology.
And then yeah, and then you can make out the interstitial infiltrate a little bit there back at 2 o'clock.
Yeah, I mean, looks like plasma cells here.
Yeah, a mixture of lymphocytes and plasma cells.
But I don't see eosinophils, which I would have expected with the PPI. I mean, with the NSAIDs, we talked about this before. It's more lymphocytic. Another very inflamed glomerulus. Here we have more open loops, but you still have a lot of mesangial hypercellularity. This looks, you know, like it's in Bowman space. It doesn't really, I don't know that I would call it a crescent at this point. It's kind of interesting. I don't think these are just epithelial cells that are very reactive, but you know, there seems to be, here's the glom to me, and then this is kind of in the Bowman space. At least that's kind of the way my orientation seems.
Yeah, I think it's a crescent forming.
Right here.
Yeah.
Yeah, it just seems like I would have expected it to be a little more solid, but nonetheless, crescent, more active lesions. I don't know if this is a little more fibrin with that caryophyllus here. I was looking to see that I don't really see hematoxylin bodies at this point. This is kind of interesting. I'm not sure what to make of it.
Yeah, I think those are red cells spilling out into Bowman's capsule, into Bowman space. You know.
And then we don't see as much of the infiltrate, but then here's another glom actually, but there are some infiltrate here, another glom, which is just a part of a glom.
Yeah.
Steve, I know you're trying to avoid the term endocapillary proliferation, and now the term is hypercellularity, but you keep saying mesangial hypercellularity.
No, I said originally there's definitely they're included. It's endocapillary. I know. I just wanted to make the point that what you're describing isn't just mesangial, because the loops are, a lot of them are occluded, which is your whole point about the creatinine being so normal despite all this proliferation. Exactly. For whatever reason, I still have a block on the new term, and I still want to call it endocapillary proliferation, but
they just call it hypercellularity.
Yeah, I don't know why I find that so hard to remember, but
maybe because we've used it for 40 years.
Yeah, and I'm falling into the old dog category. So again, I mean, it's almost got an MPGN-like look to it, to be honest with you.
Right.
You look at this one and you see they're kind of like, you know, cauliflower, if you will, because these big mesangial hypercellularity, and then you see some loops out here that are slightly open. Same thing here. But then there's, you know, endocapillary proliferation as well.
Especially at 1 o'clock.
1 o'clock right here?
Yeah.
You know, I don't, that looks like, to me, that looks like the vascular pole, but.
But you expect to see open loops though through that area.
Yeah, I mean, they're like I've said, they're very much occluded, or the ones that are open or seem very compromised for sure. Again, these are all H&Es. And this one seems to have more open.
Yeah, so actually 6 out of 14 had active lesions. I just saw a lot of endocapillary hypercellularity, a crescent, some necrosis, and then the remaining looked like this.
Interesting. So 6 out of 14 falls into the less than half category.
Yeah. Actually, then one is globally sclerosed. So then,
all right, so it's 6 out of 13.
Yeah. So 7 out of 14 have active or chronic lesions.
Fair enough. So it's falls into the diffuse category.
Yeah.
And here's one that looks a little better with this mesangial hypercellularity. The capillary walls, and I know we'll see a PAS, interestingly enough, look thick to me in some of these, in some areas, but this definitely, as you've alluded to, looks better with more open loops.
Steve, you see anything suggesting a wire loops?
Well, that's why I was wondering if some of these, I don't know if they look thicker in these areas, and it could be wire loops. Over here, they're smaller, so I don't know that it's membranous. It may be just subendothelial deposits, which we'll see. I don't know if these may be red cells here.
Yeah, not nice red cells.
But no, it's a good point. I've been looking for them. Maybe we'll see them better. Here's the PAS. One glom, we're getting just a part of it, which doesn't look too bad. Another glom. This looks like it, either maybe it's the cut, but I don't know. This looks like it may be on the way out, but there's a lot of hypercellularity, some open capillary loops. I'm not going to say, I still wouldn't be surprised if we saw a membranous lesion coexisting with all the rest of this. Here we don't see much in the way of interstitial infiltrate. And I rest my case. Here's the Jones stain. These basement membranes definitely look very ratty. I'm looking over here. I mean, they look like there might be some spikes. I'm sure these just do not look normal. Interestingly enough, this is one of the more normal looking glomeruli. I mean, there's, the loops are fairly open. The mesangium's not even all that expanded.
A lot of holes as well. Yeah.
Pardon?
A lot of holes as well.
Yeah, that's why I was using the term ratty, but yes, a lot of holes.
Yeah.
And I think, like I say, I think I see occasionally some spikes, but at this power, I may be making it up.
You have to remember, David he gave us the percent, but he always shows us the pathology. And I think it's an important point that, this is the best glomerulus we saw, but maybe half of them look that good.
Yeah, so that's a good point. Here's kind of an amazing finding, I would think. Here we do see a membranous-like lesion, IgG along the capillary walls in a granular pattern. What's kind of interesting to me, unless this is just, what's interesting to me is I don't see a lot of mesangial deposits. David?
Yeah, I agree with you. They look mostly peripheral capillary walls here.
Yeah, I really don't see them, and I don't see anything that I would suggest, at least by the fluorescence on this particular glom, as a wire loop, unless it's something like this where it's a little smoother out here. And I think the EM is going to be very helpful for that. I don't see a lot of deposits out here in the interstitium. Well, this is Bowman's capsule here, so whatever little bit of the interstitium we see. So it definitely has IgM in the same pattern along the capillary walls. IgA pretty weak, but definitely IgM. Here we go. So a better picture of the tubules, and sure enough, you see granular deposits of IgG in the basement membranes of the tubules. Was C1q positive as well?
Yes, yeah, 3+.
David, what does it take for you to call it a full house? Do you need IgA, or do you just enough there?
Yeah. You need all three. And the IgA was weak, but it was there, so it was full.
Enough for you to call it full house. Okay.
Yeah.
Otherwise, the house isn't full.
Yeah.
So this is impressive. I mean, there are just numerous subepithelial deposits here, all the way around. I mean, unbelievable. I don't see anything in the subendothelial space right here. You got a red cell. It looks like, we'll get it just kind of off into the side. It looks like there may be mesangial or paramesangial deposits, but these are two loops here, and they're just packed with subepithelial electron dense deposits.
Yeah.
Damn. Okay.
And diffuse foot process effacement.
Yeah, you know what? I didn't see. Hopefully there'll be a higher power, but okay. I'll take it. Here I can see it for sure. But man, oh man, which is what Bill's always said. It's not the deposits, it's the epithelial cell, the podocyte damage that really leads to the proteinuria. And so there is fairly diffuse. Looks like villus transformation out here as well.
Yeah.
Again, at this lower power, I don't see any real, maybe there's a subendothelial deposit right there, but you're not showing us any.
It is a little surprising, when we correlate proteinuria with foot process effacement, this doesn't support that story that well.
Well, I mean, we have fairly good effacement here. There's some areas that are preserved, and David will give us a percent. Here we go.
I'm not denying the effacement. I'm just saying I'm surprised this. Bill thought they would not be that bad. I believe because the effacement, because the proteinuria wasn't so high. But
Yeah, I actually used the term pristine, and this is anything but.
By the way, who was it that said this would be membranous, possibly with a proliferative lesion? I'm trying to remember.
I think all of us may have said that. I don't think it was
I
that
don't.
unique.
I remember a lot of people talking about proliferative lesions. I don't remember the membranous.
I think it was a seam.
Yeah, it could have been. Here we have what look like subendothelial deposits. And
Yeah, small. Yeah,
fewer
they're only focal and
intramembranous,
small.
but no humps. I mean, no humps, no big, massive subendothelial
Right.
deposits.
Yeah.
So-
Yeah, yep.
Steve, you know, given where the deposits are, you know, how chronic do you think this is? Steve?
No, I'm. Can I have a few minutes? I'm trying to get my thoughts together. Well, you had 4+ protein 6 months ago, right? And you said that sometime in 2020, you had 4+ protein. It looks, I mean, it's not super acute because, you know, it's not like they're what we would call CHERG1 in the, you know, primary membranous, but there are definitely spikes and holes. You know, this isn't something that's been going on for years, I wouldn't think, because I would expect it by, you know, if this had been going on for, you know, at least a year or more, I would have expected intramembranous deposits and/or deposits being kind of absorbed. And the capillary walls on the PIS stain didn't look that bad. You know, they didn't look real thick, and many of them actually looked pretty decent when we saw them. And I don't know if this glom that we see here is a one-off, and if they would have gotten another glom, I don't know how many gloms were on the EM. It might have been a little different. But
I wasn't trying to be tricky. I just trick or anything. I just think it's I think it's
more acute
pretty
than
new.
chronic. No, I agree. I think it's
given
more
her long
acute.
history of lupus and a proteinuria, I'm surprised that there were no real intramembranous. They were all subepithelial. There wasn't.
You're spot on. I'm even more surprised with the hypocomplementemia and stuff that there weren't big subendothelial deposits, you know, that we would normally see. And this gets back, I mean, it definitely wasn't Pauci immune. I mean, you know, what's also amazing about this, and I know I think I know where you're going to go with all of this ultimately, but what I'm almost as amazed by is how the fluorescence was so unremarkable for mesangial deposits and somebody has such bad lupus. You know, there's definitely I guess David put it into the category of 4G, I'm assuming, because these didn't look segmental and necrotizing. So I would assume this is going to be, if we use the older classification. I know they've gotten away from the GNS, but I still like it because I think there's still some, you know, pathologic significance to it or pathogenic significance to it. So I would assume there's like a 4G plus 5. And I think the plus 5 is as much a component of this as anything, which is leading to this severe nephrosis. You know what we didn't see? I know I'm rambling on, I'll stop because I know you've got slides. I don't remember seeing a lot of protein reabsorption droplets.
Well, that's a good point because it kind of goes, you know, we keep going back and forth on the albumin and the proteinuria, and some support this, and then the foot braces doesn't support that.
We've seen this before, and I've seen it. I've had primary membranous patients come in with like very low urine proteins and a low albumins, and we start giving them albumin infusions and Lasix, and all of a sudden you measure another urine protein, and it's like 40 gram per gram or something, you know. So I still think that may be an issue here. But anyway, membranous plus you know, diffuse proliferative lupus nephritis, like a 4G, with acute interstitial nephritis, which seems to be more lymphocytic and plasmacytic. Whether it may be due to the NSAIDs or not would be an interesting thought. I assume the PLA2R was negative.
We don't have it.
And we're not able to check for, and I always mix up this name of the, you know, the lupus membranous.
Exostocin, no.
Exostocin. All right. So I will stop.
I think we have a poll here. So please vote, people. Pravir, the faculty can vote or no vote?
No, the faculty that can't vote, so you can put it in the chat and see what you would decide.
Hold off on the chat. I mean, please, people vote. I want to see what people are. There's a lot of options here.
Yeah.
I'm going to take our time, but I want people to vote.
So this
no
is
one will know what you voted
therapy,
for.
Right?
This is initial therapy. So you got the patient now. What would you use for this patient?
In a way, it's kind of refreshing to have a patient who's naive to therapy. So often we have people that have already been treated with Benlysta and Cellcept or something, and then we biopsy them to see why they're refractory. And so we don't really get these fresh new ones that frequently. And that's really what's been in all the studies. So it's kind of nice to see.
Yeah, it was nice Roger sat on this for a while.
We have a pretty good, actually we have, let's see, people
I'm
coming
gonna
in.
get a few more minutes here. We've
Yeah.
got a few more votes coming in.
Yeah. And I'll share the results. Okay. 10 more seconds here.
Yeah, see people still voting.
Is Dick
Don't
on
be
the
shy.
line? Did
Dick's not here today. No.
He's not.
All right.
Want to share? Can you do that?
So,
Can people see that now?
Nice.
Everybody sees it?
yep.
Okay. So we've got 42% MMF with steroids, 40%, 38% IV Cytoxin with steroids. We got 1 oral Cytoxin with steroids, and actually 4 Rituximabs. I thought somebody might bite steroids alone, and it's interesting that now with all the talk about Benlysta and voclosporin, nobody picked those therapies. Not saying they should have, but it's it's very interesting. So I want to talk about the history of the treatment of lupus nephritis. Let me see if I can control.
Go ahead and click on the screen. Yep.
All right, I guess we ought to
Yep.
strap in.
Yeah, I know this is going to be a little longer than usual, but it's still worth
great.
going through. It's a great story,
Great.
and it's a great story. What goes into treatment is multifactorial, and we came up with 4 different treatment options that people chose out of the 7 that were given. But you've got to take into account compliance. It's always an important issue, and that might be why some people picked option number 2, IV Cytoxin plus steroids over MMF. I think that's a very reasonable consideration because she has not been very compliant. I mean, she was severely hyperthyroid and she wanted medical marijuana for it. You have to consider side effects. She's a young woman, and there's always the consideration of infertility, and I'll get into dosing a little bit as we go along, the different protocols and dosing, but that and hair loss and everything else, and efficacy. There's availability. Sometimes some of these things aren't always available. Route of administration sometimes plays a role, and cost is a big factor now, especially with the last 2 treatments in the poll, voclosporin or actually all 3, Rituxan, voclosporin, and belimumab. They're not cheap therapies, and so there's a lot of things that go into the decision, and it isn't just a matter of picking one over the other. I think that it's complicated and it has to be tailored to each person's pathology, their sometimes even their races. I'll get into. So getting to the history here, in 1930, adrenal extract was available for patients with Addison's disease, and it basically saved their life. Before that, there was no chance of survival. And then in 1950, cortisone was produced, and it was basically used for arthritis, and it changed many people's lives. And they won the Nobel Prize in Medicine was given for the discovery of and development of cortisone. That still was being obtained from adrenal extract. It wasn't being produced at that point. By 1955, prednisone was produced. Cortisone has mineralocorticoid and glucocorticoid. So prednisone was now starting to be produced, which is predominantly glucocorticoid. And then in 1955, doctors Kark, Murky, Pirani, and Pollack, these guys were all from Rush and U of I. It was kind of a combined program at the time. Started publishing their evidence with renal biopsy and lupus nephritis, and a lot of the next literature for the next 15, 20 years was all of theirs. So we're real proud of being part of that at Rush. Here are these gentlemen. This is Dr. Bob Kark. This is Dr. Bob Murky, Dr. Conrad Pirani, and Victor Pollack. And they published this paper about actually using the renal biopsy. But I want to read the very first paragraph. I know a lot of you have heard this, forgive me, but it's such a great story that it's worth repeating. So for the few of you who have it, might enjoy it. It says the key apparent kills sheep by pecking at their kidneys with its large hawk-like beak. The human counterpart of this bird makes ill-advised stabs with large bore biopsy needles at the kidneys of patients and is astounded when he lacerates the organ and endangers the patient's life! Exclamation point. Besides laceration of the kidney, other major potential hazards of renal biopsy are retroperitoneal hemorrhage, renal infarct, anuria, and dissemination of infection. In the past, biopsy of the kidney was considered too dangerous, but in 1951, Iverson and Brun showed that in the right hands with proper care and technique, the procedure is safe. And that's where we really are, today. We've completely changed the procedure over the year and how it's done and the visualization and the follow-up. And in fact, to date, Iverson and colleagues, Parrish and Howe, Jackson Associates, and our group have done just under 800 biopsies among us without a single death and with little morbidity. So this was the beginning of a whole new history of glomerulonephritis, especially lupus nephritis, because before then you really didn't have the access to be able to look at the kidney. And here's a picture of this nasty bird attacking a sheep and getting down there. And these sheep would often bleed to death. They would peck down there and get the perinephric fat. And sometimes they would bleed to death. But what followed was, starting to look at studies. And so in 1957, the same group presented their results of cortisone for lupus nephritis. Now they were able to diagnose lupus nephritis by biopsy. And they gave cortisone in 10 patients, but it was like 50 milligrams of cortisone, which is the equivalent of about 10 milligrams of prednisone. So no surprise they all died. Then in 1961, the same group, now because prednisone was available as the main anti-inflammatory agent, they gave 50 milligrams of prednisone for patients with lupus nephritis. Now they had an N of 16 and 9 survived. So that was a very big deal. Before then, pretty much it was abysmal survival if you had lupus nephritis. So that was a real game changer, the development of prednisone and realizing the right dose. And by 1964, Victor Pollack published his results basically became the standard of care, was 1 milligram per kilogram per day of prednisone with very good results. Interestingly, I think we're starting to cut back on that, but that was pretty much the case for the next 40, 50, 60 years. 50 years would be 1 milligram per kilogram per day of prednisone, whether it was included with other drugs or not. And then in the 1960s, nitrogen mustard became available, which is the precursor, which made 6-mercaptopurine, which is a precursor for azathioprine. And then in the 1970s, both azathioprine and cyclophosphamide really became, these are alkylating and chemotherapeutic antimetabolite agents that became available, being used for multiple things, and of course, being used now for lupus nephritis. And what that led to was then in the 1980s was the NIH protocols that came out, and this dominated lupus nephritis for a long time. They realized this was a non-controlled. They basically went back and looked at all the patients they'd given IV Cytoxan to over the last 10, 15 years and reported the results in the New England Journal of Medicine, and where they were giving monthly Cytoxan, IV Cytoxan followed by every 3 months, and up to 3 years they would give these drugs with a cumulative dose of 24 to 28 grams of cyclophosphamide. Now that's in the range where you really have to worry about infertility and even long-term cancers, bladder cancer and lymphomas, etc. And then in 1986, the collaborative study group, which was at Rush, we did the Plasmophoresis Trial. Dr. Lewis was the PI. So when I say we, I say Dr. Lewis being the PI, we. But this was a multi-centered trial, I believe 86 patients. And this was using oral cyclophosphamide. And they only gave it for 2 to 3 months. So it was a much lower dose, a cumulative dose of 9 grams, but much faster administration. So it was a very fast upfront dosing along with steroids. The trial was just to determine whether plasmapheresis helped lupus nephritis. It did not, but we learned an awful lot about the treatment of lupus nephritis with the Cytoxan and prednisone and the histologies, et cetera, related to that. So now we're down to 9 grams of significantly less Cytoxan. Right around 2000, MMF had been around for a while, but hadn't been really used for lupus until 2000, went out of China. There was a study that compared it to IV Cytoxan and found it to be equivalent. And this was kind of a game changer because no one really considered anything for diffuse proliferative lupus nephritis except Cytoxan, either IV or PO cyclophosphamide. It wasn't necessarily accepted right away. I remember Dr. Lewis would always joke, he'd call it Cytoxan light. He had a hard time accepting that something that was non-cyclophosphamide would be able to treat lupus nephritis. Then in 2002, Lupus came out. That was a different protocol altogether. They gave 500 milligrams every 2 weeks for 3 months, so a total of 6 doses or 3 grams. So we've gone from 28 cumulative dose to 9 grams, now to 3 grams. Actually, it was interesting. They did pulse with high dose steroids, but they also used 1/2 milligram per kilogram per day. So this is, when you look at the dosing of Lupus, it's less Cytoxan, and it's less steroids as well, and found it equal to the other regimen. And the only criticism there being in Europe that it was all mostly Caucasians, and some people have always questioned that as well. The same thing here. It was with China. It was with MMF was all Asian, and maybe this doesn't apply to your typical European Caucasian. So you've got this problem here. And then the Alms trial came out, which really covered all ethnic groups and tested MMF versus IV Cytoxan and found it to be equal. Interestingly enough, African Americans had a better response to MMF than the IV cyclophosphamide. The only other caveat of this trial was that the patients that received MMF, they had more relapses than the IV Cytoxan, cyclophosphamide. So you're kind of left with a little bit of a mixture here, but I don't think it's Cytoxan light after Alms. I think it's fairly accepted, and clearly it's accepted therapy. 42% of our people picked it on the poll as their first choice here. This is the Alms trial, and you can basically see the equivalence here across the Caucasian and the Asian. The real question here was, because the first China trial was Asian, that whether or not it would apply to Caucasian, but it did. A small subset, as I mentioned, the African Americans appear to do better with MMF. The next study was Rituximab that came out in 2013. This was a steroid sparing protocol. So the idea here was they did get IV pulse doses of steroids. These are all patients with lupus nephritis. And I will tell you that a lot of these trials have a mixture of 3s, 4s, and 5s. Not all of them were limited to 4s. And that could be argued, you could argue that it matters, you could argue that it doesn't matter, but a lot of these trials had a lot of membranous, and the cover study group did not have any pure membranous in their lupus nephritis trial. So Rituximab, they got pulse with steroids, and they got Rituxan, and then that was followed by MMF. So it was considered a steroid-free protocol, except for the loading dose with the pulsing. There was no comparator there. It was only their own experience, but they had a very good response to therapy. And
those patients were membranous isolated, just like you were saying. The lesion does matter. I think it was almost 50% in that study, and the Rituximab had membranous.
Yeah, and it's actually a good argument for using Rituxan for lupus membranous, and it may be why 4 people picked Rituximab in this case, since there was a very significant membranous lesion, at least histologically here, along with the proliferative lesion. Then around the 2010s, CNIs began added as multi-targeted therapy, and there was a number of studies looking at that, but not really randomized very well. But it became a very popular treatment. And then just last year, belimumab was in the New England Journal of Medicine, and was found. It was been listed as added to standard of care. So we're talking about IV, Cytoxan here and prednisone, or MMF and prednisone, and it had a significant improvement. At least probability of renal relapse, event, or death seemed to was significantly less, and that led to its approval now. I don't think we really know where this fits in, but it was fairly significant finding. And then the voclosporin, it was actually a study done in KI in 2019, but it just got approved again in the last year or 6 months or something for lupus nephritis. And here you can basically see that, placebo meaning standard of care, and you can see the increased response rate with voclosporin. And now we have 2 new drugs. They're very expensive that might be add-ons for patients with induction therapy. Nobody picked either of those in our poll, but it is interesting to see that they may be options. And I don't know where they're going to fit into. Are they going to fit into our patients with more membranous, for instance, voclosporin? If they've got more membranous, is voclosporin any better than any other CNI? We don't know that because it was, is it a class effect or not? And no one's ever really tested it in that way. Certainly, it's a very expensive drug, and maybe some of the other CNIs will work as well. Will people take that chance? It's always the problem with the new drug. Is it a class effect or not? And where does Benlysta fit into this? Is it just for steroid sparing, or is it an addition? So we don't really know. We don't know what is going to be the next thing in 2023 and 24. But clearly, there has not been stagnation in the history of the treatment of lupus nephritis. It's a fascinating history. It's a lot of rush history. We're very proud of it. But what used to be a universally terminal disease now has a pretty good future if you can catch it early. I think this woman was lucky that she was not caught early. But if you look at her pathology, it's really, she had a very bad membranous lesion, but the glomerular lesion was not that necrotic. There was, I think, one crescent, a little bit of necrosis, but basically glomeruli that completely plugged up with cells. Here's her, what was decided for her was she was given prednisone. The majority picked what she got. She got prednisone and MMF. You could see her serology. This is 3 years ago before we're treating her with, I guess, 4 milligrams of prednisone a day. And then at presentation, she became very active with hypocomplementemia and a much higher double-stranded DNA. And then on follow-up, her double-stranded DNA has come down. This is a few months later, and her complements have improved. So at least serologically, she's improved. Her creatinine was never anything to be able for us to look at. And here's her urinalysis before and after. And she's still, we didn't have a lot of proteinuria. We don't have a repeat protein creatinine ratio. Her albumin's slightly higher. I didn't show it here, but it's still not normal. And this was about a month ago. So I think it's still early in her treatment. And she still has, fairly active urine. Interestingly, the white cells are down, which is pretty impressive. And that might certainly be the steroids. And there's less red blood cells. So I think she's responding both clinically and serologically. And I think that was a very good choice. And she obviously feels much better than she did. So I'll be seeing her shortly, and I'll be able to get a better idea how she's done. But I think that was a good choice, and I think she has a very good prognosis if she takes her medication. I was worried about the MMF because I was worried she would take it, but I think she learned her lesson. But I hardly, given her history, would have any problem giving her IV Cytoxan and steroids for a compliance issue, and I certainly wouldn't have had a problem with Rituximab either. I think they're all pretty equivalent as far as we know. They're more equivalent than non. I think they're equivalent until proven otherwise. Anybody have any other thoughts about treatment regimens or what you would do? No?
I just have a comment about the class effect of the CNIs. They do have studies looking at the pharmacokinetics of the different CNIs, and they are actually quite different because they realized that the cyclosporin was really efficient for treatment of psoriasis, but voclosporin actually was terrible. So when they did pharmacokinetic studies, they found out that the calcineurin inhibition is much better with voclosporin around the circulation, around the blood vessels, but it doesn't have deep tissue penetration. So if you look at skin disease, voclosporin is much inferior. If you look at organ transplantation like kidney transplant, Prograf and voclosporin are about, or at least it's not inferior to Prograf. When it comes to lupus, it's actually better. So there does seem to be a differential in response to CNIs depending on what organ and how much tissue penetration you need from the CNI.
You said it was better with lupus. We know that.
We have there's definitely less renal and cardiovascular toxicity with voclosporin, which is why it's being touted as the CNI of choice for this. And we do have pharmacokinetic studies that it does preferentially suppress calcineurin around the circulation, which is a blood vessel disease, which what lupus would be considered to be.
It's interesting. Thanks.
Yeah.
So are there voclosporin levels as well that are available or no, like there are with tacrolimus and cyclosporin?
I don't know if there's commercially available, but in the studies they do measure it. Yeah.
And the other thing is, in multi-targeted therapy, the first article I remember was the one that came out from China. And that was the one that Dick had written the editorial on, and that was tacrolimus. For sure, Howard Austin and lupus used cyclosporin. And Casey, have you seen anything that compared the two of those in lupus membranous or lupus nephritis?
I have not.
Yeah, I was just curious.
Well, fortunately, I think her prognosis is good. I think she probably would have done well with any of these, and I'm really, glad that that she's taking it, and I think her prognosis is good. So I'm going to wrap this up. Thanks everybody for showing. The CME activity code is 482404. This will be posted on YouTube in a few weeks. We appreciate your attendance, and sign up on YouTube for our channel. And everybody stay safe, and we'll see you next week.